And now I have the pleasure of introducing Dr. David Neubauer today. He received his medical degree from University of Miami School of Medicine. He completed his psychiatry residency from Johns Hopkins Hospital, where he was also a chief resident. He's currently an associate professor of psychiatry at the Johns Hopkins University School of Medicine and senior faculty of the Johns Hopkins Sleep Disorders Center. Dr. Neubauer has also held leadership positions in many national societies and has appointments on multiple editorial boards, including Sleep. He has served on the board of directors and executive committee of the National Sleep Foundation. He's also the author of the Understanding Sleeplessness, Perspective on Insomnia, published by the Johns Hopkins University Press. He's written numerous journal articles and book chapters on sleep-related topics. He co-authored the 2017 American Academy of Sleep Medicine Clinical Practice Guidelines for the Pharmacologic Treatment of Chronic Insomnia in Adults and has lectured in courses in sleep nationally and internationally. In fact, he was just back from Rio de Janeiro for the Sleep Conference. He's also done a lot of general public-oriented activities to stress the importance of healthy sleep as a key component in the pursuit of wellness, and has been featured in many major news channels and has written on sleep-related topics in the major newspapers. So thank you so much for being with us, Dr. Neubauer. And without further delay, I would like to hand it over to you to share your expertise on pharmacotherapy of insomnia.
Well, thank you so much. I appreciate the introduction and happy to speak to your group today. I'm going to back up to my title slide here, Insomnia Pharmacotherapy. So it's a large topic. I apologize in advance. So we're moving relatively swiftly. A lot to talk about generally on this topic. This is the disclosures. You'll see that I've been a consultant for ASI and for Idorsia, relevant for this talk, but I think you'll find it a well-balanced talk. So we have a lot of options in treating insomnia. We certainly want to educate our patients about sleep and circadian rhythms. We want to promote healthy sleep habits, regularity, and a conducive environment, and caution about using various kinds of substances that might affect their sleep. Clearly, we want to optimize the management of comorbid conditions that might be influencing sleep. Certainly, there's abundant evidence for cognitive behavioral therapy for insomnia, and we want to use that whenever possible for our insomnia patients. We may turn to various circadian strategies with light or darkness being used at strategic times. There's evidence for head cooling devices to treat insomnia and various other new technologies. And for some patients, we will turn to using medications, most of them directly targeting sleep as sedating agents with particular pharmacologic characteristics, but some of them work indirectly, facilitating sleep by reducing arousal. Insomnia is not a new problem. There's interesting literature going back for millennia. Here's a Middle Ages recipe for laudanum, and you can see the opium poppies. And a few hundred years later, we had products like this, this opium alcohol solution. You can see the prescribing guidelines, age 15 to 30 years at the top. I don't know about after that what you're supposed to do, but you can see at the bottom recommendations for treating your 2 to 4 year old with opium and alcohol. We've come a long way, and we have much safer and effective medications available as well. So I try to put everything into one of these 4 categories, and you can see there's a question of whether or not there is a formal indication here from the FDA and whether a prescription is required. So there are the dietary supplements, which don't have any indications and relatively no regulatory oversight for them. And of course, you don't need a prescription. Now, there are the other over-the-counter products that do have formal indications and do have a lot of regulation, but of course, here you can see do not require a prescription. Then really the largest category probably is the medications that are sedating but are prescribed off-label. And of course, you do need a prescription for those. And then finally, here is the category of those that the FDA has actually approved for treating insomnia, and these are all prescription medications. So we'll start off with the dietary supplements, so herbal preparations, sometimes labeled as homeopathic, some of them are vitamins. They're thought of as, quote, natural, and so they're appealing from that point of view. And though technically they are regulated by the FDA, it's the F part, the food part. So there's no need for any evidence of efficacy for these products to be marketed. There are two broad types. There is melatonin, and then there's everything else. Melatonin sort of makes sense. We make our own melatonin. It has a critical role in circadian rhythmicity, and so it makes sense that perhaps it might be beneficial. And then there are a whole lot of other things for which there is very limited evidence for any sort of efficacy. Fortunately, for most of these, there are a few safety concerns associated with them. As you know, there are just a huge number of products that are marketed as sleep aids that are dietary supplements. Melatonin alone is estimated to be used by about 3 million people in the US at any particular time. So just very quickly, here are some of the assorted ingredients that you see in many of these products. And a lot of the products actually include multiple substances. And as I mentioned, most of these are pretty benign in terms of safety. The one exception is kava, for which some countries have banned it, and the FDA has issued a report about potential liver damage associated with it. Back to melatonin for a moment. If you go on Google and look at images for melatonin, you can do this all day long, having more and more of these products. And you can see some are tablets, some are capsules, there are liquids, there are gummies, there are all sorts of ways to get melatonin, and a rather surprising range of doses. We usually think about maybe 0.5 milligram or 1 or 3 milligrams, but you can buy 10, 20, 60. I've seen 120 milligrams of melatonin available online. Here's a standard list of possible side effects. I got this on drugs.com, but there are various other studies looking at different side effects. So drowsiness, dizziness, weakness, confusion. Here's what I see most often: people complaining of vivid dreams or nightmares, but I don't really see depression, anxiety so much. Maybe headache. I really haven't seen these GI symptoms so much. Blood pressure changes, joint or back pain seems unlikely. Elevated risk for seizures, also, I don't think so. Let me remind you just very basically what melatonin does. So we have reinforcement of the suprachiasmatic nucleus, from our light exposure, and it's really the SCN that regulates the activity of the pineal gland in producing and releasing melatonin into the bloodstream, into the cerebral spinal fluid. And you can see it's a really circuitous route way down through the superior cervical ganglion in humans anyway. And so it's the SCN that determines when melatonin is released and has its influence on sleep, rather than other factors directly affecting the pineal gland. So it's the SCN turning the pineal gland on and off, but it turns out that there's a very high concentration of melatonin receptors in the suprachiasmatic nucleus. So it creates this reinforcement through this feedback loop, in a sense. And the robustness of our circadian system is in part due to this cycling of melatonin release during the nighttime, and it being low during the daytime. So just to remind you that melatonin levels are low during the daytime, and you can measure them in the plasma or saliva or in the urine, the byproduct at nighttime. And it's possible to measure the dim light melatonin onset for a particular person. There are some people who have it early, some people later. And similarly, you can measure the dim light melatonin offset in studying patients clinically, but certainly in research settings as well. And here's a familiar chart where we have the homeostatic drive, increasing from the morning until we finally fall asleep, and then being reversed during sleep itself. We don't feel progressively sleepy as the daytime continues, and that's because late in the day we are rescued by our circadian system. So it is circadian arousal in the evening that is allowing us to stay awake and alert for the 16 hours or so, and then that arousal decreases and that homeostatic drive is no longer countered by circadian arousal, and therefore sleep onset is relatively easy once that circadian arousal has decreased. And it's really the onset of melatonin as bedtime approaches that facilitates sleep onset. So melatonin really is helping to facilitate sleep, not so much because it's sedating, but really because it's helping to decrease that circadian arousal. I want to briefly talk about some of the problems that may be associated with melatonin. There's been really interesting research over the past 10 to 15 years about the potential metabolic consequences, and want to highlight this one study. This is actually from 2014. Healthy young women were given glucose tolerance tests on 4 different occasions: in the morning at 9 a.m. With a placebo, and another day with melatonin. And then they did it in the evening as well at 9 p.m. Again, one occasion with a placebo, another occasion with melatonin 5 milligrams. What they concluded was that acute melatonin administration in humans impairs glucose tolerance in both the morning and evening. And when administering melatonin, the proximity to meal timing may need to be considered, particularly in those at risk for glucose intolerance. So look at this. You can see on the top left, this is the morning, and the glucose rise for these individuals, same people, different conditions. So in the darker melatonin squares, you can see that the glucose is much, much higher, going out to that 3-hour point in the glucose tolerance test. Right below that, the insulin increase in the morning is not so much. But now look at the evening, and you'll see at the top with glucose, there's even a higher release with melatonin compared to the placebo. And then down at the bottom, still for 3 hours, you see an increase in insulin. And, metabolically, in terms of the circadian system, we all become slightly pre-diabetic naturally in the evening. And this suggests that we should be cautious with our use of melatonin late in the day or close to meal times. So this opinion piece from experts just a few years ago concludes this: the concurrence of elevated melatonin concentrations with food intake decreases glucose tolerance, while high melatonin during the fasting may facilitate B-cell recovery. And they say shift workers, night eaters, and melatonin users are susceptible to the adverse effect brought by the concurrence of food intake and high melatonin levels. We're really designed to eat during the biological day and fast during the biological night. Now, everybody's biological night onset varies a little bit depending on their circadian predisposition, but eating late is probably not a good thing for most people. Here are my takeaway points if somebody is going to use melatonin. Mainly for sleep onset, unlikely to help for sleep maintenance, most likely helpful for people with circadian rhythm phase delay or perhaps non-24-hour disorder. Limited support for jet lag, shift work. Maybe try a low dose, 0.5, maybe 3 milligrams. There's a flat dose response curve, and so taking more and more and more for sleep onset anyway is probably not beneficial. Take it prior to bedtime, but not too early, at least 2 hours after the last meal. And we should avoid eating late in the evening, even if you're not taking melatonin, just because of our own endogenous melatonin coming up. All right, next category is the over-the-counter sleep aids. So as I mentioned previously, these are regulated by the FDA. That is really good. So we can trust their composition and dosing and manufacturing and labeling and marketing as well by the Federal Trade Commission. They're all antihistamines. There are brands that we're familiar with and tons of generic options available. They do have a direct sedating effect, although tolerance is possible. There are the familiar products, and many of them are the PM formulations that include analgesics as well. And of course, you may need a prescription for some of the higher doses. So all are antihistamines, and there are really just 2 of them in these products. Diphenhydramine is in most of them. You can see the elimination half-life is about 8.5 hours. Of course, children will metabolize it more quickly. Elderly individuals, it'll be longer. And doxalamine is the other one, and that's even a little bit longer half-life. So these may be problematic from that point of view. So they're antihistamines, so we know there's postsynaptic H1 receptor blockade, but they're not all that clean because they're antagonists for the muscarinic acetylcholine receptors as well. So I mentioned tolerance to sedating effects may develop with daily use. That can be problematic. Typically someone might take 25 or 50 milligrams. I've been impressed with patients that I've seen for evaluation in our sleep clinic who are taking surprisingly large doses. Years back when I heard patients say they were taking 100 milligrams or 200 milligrams, that seemed like a lot to me. And then somebody coming in saying they were taking 400 every night and then 500 and 600 milligrams nightly is the record so far that I've heard from a patient. And of course, this is all because of the tolerance to the medication. So adverse effects, sedation, anticholinergic symptoms as well. I'll mention hydroxyzine. It requires a prescription, but I just want to mention it here because it shares many of the characteristics of these other two over-the-counter antihistamines. So residual effects, grogginess in the morning. I've seen just full-blown delirium in people coming on rapidly, especially older individuals or people taking other medications with anticholinergic effects when they've taken one of these products at the regular doses just for their sleep. I've seen urinary retention as well. There's potential for dry mouth, blurred vision, exacerbation of narrow angle glaucoma. So greatest risk, elderly individuals and people taking other anticholinergic medications, of which we prescribe quite a lot. So, and good to be cautious. So our third category, and these are the assorted sedating medications that I call off-label. So they do require a prescription, but they're not indicated for the treatment of insomnia. So you're all thinking appropriately that antidepressants represent the largest part of this category, and you're thinking trazodone, mirtazapine, higher doses of doxepin in the old days, amitriptyline as well. But also some antipsychotics are used, sometimes exclusively for insomnia. Quetiapine, of course, would be the example here. Anxiolytics, these would be mostly benzodiazepines that are not approved for treating insomnia, things like alprazolam, clonazepam, lorazepam, and others. Antihistamines at higher doses, anticonvulsants, mood stabilizers, and that would mostly be gabapentin, maybe pregabalin, antihypertensives, clonidine, anesthetics, well, propofol, sometimes used, but not a great choice in the long run. What's lacking for all of these is evidence for efficacy in populations of insomnia patients, and also good assessments of safety in insomnia patients as well. So we don't have prescribing guidelines for these medications. And in many cases, we really don't know the effects on sleep. The big question is, does the individual have a comorbidity with an indication for one of these? So if I have a schizophrenic patient and they're having a lot of trouble with sleep, then quetiapine may be a very appropriate choice for that individual. I want to say a little bit more about trazodone. So trazodone is the number one drug that is prescribed for insomnia. I suspect that close to 100% of the current trazodone prescribing is for insomnia.
Dr. Neubauer, can you hear us? Dr. Neubauer, can you hear us? You appear to be frozen.
Was that him, Debbie?
I
wasn't sure if it was mine.
I think it's him.
Okay. Okay, so I think it was for everyone.
Christina sent that message. Oh, it's different. She really enjoyed talking to you.
Yeah, so I think the audio was lost at the very beginning of president section, so it was for everyone.
Yeah,
You know, she enjoy it.
Dr. Neubauer, can you hear us? You appear to be frozen.
I can hear you.
Okay, we can hear you now.
Okay, good. That's because I unplugged my camera and put it back in.
Okay, I think we lost you right after trazodone, so starting trazodone.
Oh, okay. Well, let me go back a few slides and I can. Let's me. Okay. Well, I'll quickly say that you know, trazodone has complex pharmacodynamics and pharmacokinetics, and if people are prescribing it, they should prescribe it wisely. You know, rather than just thinking that it's a benign alternative to the controlled substances and other FDA-approved medications. You know, right out of the label, there are these warnings about suicidal thoughts and serotonin syndrome, which I have seen when people have combined trazodone with other serotonergic medications. You know, there's potential for QT interval prolongation. We often see orthostatic hypotension with it. Priapism should not be overlooked when it occurs in women because it's less obvious. Activation of mania, hypomania, cognitive motor impairment potentially as well. And we sometimes see hyponatremia with it as well. Okay, so finally moving on to the last category of the regulatory approved insomnia medications. We have four major pharmacodynamic categories. There are the benzodiazepine receptor agonists. Some of these structurally are benzodiazepines, and some of them don't have the structure but have very similar pharmacodynamic action. So sometimes these are also called positive allosteric modulators. Then there are the melatonin receptor agonists. In the US, we have Melatonin. Some other places, some countries have a controlled release melatonin formulation that is prescription required. We have a single selective histamine receptor antagonist, very low dose doxepin, under 10 milligrams. And then we now have three dual orexin or hypocretin receptor antagonists, and we'll talk more about all of these. So here's a chart that shows all of the FDA-approved benzodiazepine receptor agonists. You see at the top, there are the 5 old ones, the available doses, and look at the elimination half-lives, because while they're, triazolam is relatively short, the others potentially are just incredibly long with half-lives of several days. And obviously this can be very problematic even after a single dose, but certainly when somebody reaches their steady state, it may not make much difference if it's daytime or nighttime. Then there are the 3 non-benzodiazepine, very popular immediate release medications that have been around starting in the early 1990s into the 2000s. You can see the available doses, and the elimination half-lives are very short. So that's probably one of the major advantages of this category. Zaloplan having a half-life of about 1 hour, zolpidem about 2.5, maybe 6 to 9 hours with esopiclone. So much decreased risk of daytime sedation. There is an extended release version of zolpidem, been around for quite a few years. And then there are these alternate delivery ones that I don't think are used very often. There is an oral spray. If you spray once, it's 5 milligrams. If you spray twice, it's 10 milligrams. There's a sublingual bedtime dose, and then a middle of the night option that is very low dose, another oral dissolvable product. So these work through the GABA A receptor complex. This is transmembrane 5 subunit ion channel receptor, and basically there's a higher concentration of the chloride ions extracellularly when GABA attaches at its site between alpha and beta subunits. It allows more of those negative chloride ions to enter, and therefore having an inhibitory effect. There also is a separate allosteric benzodiazepine receptor site, and when there's an agonist at that site, it allows more of those negative chloride ions to go in. So basically, it is enhancing what normally occurs when GABA itself attaches. And you can think about the generalized inhibitory effect through this process. So clearly there's the hypnotic effect with certain medications depending on their pharmacokinetics, but there's also the muscle relaxant, anticonvulsant, anxiolytic effects as well, sort of shared by that mechanism. So just looking at the benzodiazepines, pharmacodynamically, they're positive allosteric modulators of GABA responses at the GABA A receptor complex. So the benzodiazepines interact with multiple receptors depending with a greater variety of these alpha subunits, subtypes. So there's targeted action in the hypothalamus to enhance sleep onset, but there are also global CNS effects with the benzodiazepines. The ones that are approved for sleep are relatively rapidly absorbed. They vary widely, as we've seen, with their elimination half-lives ranging from hours to days. We should expect a longer duration in older individuals. And so these may be efficacious for sleep onset and sleep maintenance, and certainly there is that potential for daytime sedation. So in contrast, the non-benzodiazepines are the same in many ways, but they're more selective for the GABA A receptor alpha subunit subtypes, shorter elimination half-lives, and limited potential for residual effects in the daytime. For all of these, there are a lot of potential adverse effects. We could spend the entire lecture talking about these potential problems. There may be the residual morning effects, dizziness, headache, somnolence, blurred vision, nausea, diarrhea, fatigue, ataxia is certainly possible with all of these. There's anterograde amnesia, and particularly with the non-benzodiazepines, there are concerns about somnambulism, complex sleep behaviors. There's a boxed warning for the non-benzodiazepines in the prescribing information for potential injuries and even deaths that may be associated with these symptoms. So moving on to the next category, the melatonin receptor agonist. In the US, we do have Remeltion. It is a receptor agonist for the MT1, MT2 receptors, and there's targeted action in the suprachiasmatic nucleus, helps to reduce evening circadian arousal, facilitating sleep in that manner rather than being, directly sedating. So it reinforces circadian periodicity and can be beneficial for sleep onset, and that's what we'll see as the indication, not for sleep maintenance. So it's pretty rapidly absorbed, short elimination half-life, and as I say, residual daytime sedation is less likely to occur. Indicated for insomnia characterized by difficulty with sleep onset, pretty well tolerated, somnolence, dizziness, fatigue, pretty low, no abuse liability, should be avoided with hepatic impairment or the use of fluvoxamine, which is an inhibitor for numerous metabolic pathways. There is doxepin, at very low doses. So it is primarily a histamine receptor antagonist. It is so much more selective from the other tricyclic antidepressants. It really stands out for that purpose. So histamine itself is a potent wake-promoting neurotransmitter, and so the low-dose toxaben enhances sleep by reducing nighttime histamine arousal. Rapidly absorbed, it has a relatively long half-life of 15 hours, but it's a super low dose. So there's relatively low potential for daytime residual effects. The indication is for insomnia with difficulty with sleep maintenance. It might help with sleep onset, but really the evidence is much stronger for sleep maintenance. The indication was for these two doses, 3 and 6 milligrams, although, an alternative is using the liquid formulation, which, you can do any dose you want. And I often use that starting off at about a 5 milligram dose. Again, no abuse liability. There is some risk for somnolence and sedation, nausea, upper respiratory tract infections. So here's the summary of these other non-benzodiazepine medications, the Melatonin, the doxepin, and then we see the 3 dual orexin receptor antagonists. And so since those are recent, I want to focus the rest of the talk on how these came about. And it all started in 1998 when the orexin hypocretin system was first reported. So this is very recent activity. So these 2 articles were published, I think, just about 2 weeks apart. And it's so fascinating because these 2 research groups working independently were working from like opposite directions and came up with the entire system of the neuropeptides and the receptors and the proteolytic action of the longer peptide. So one group was in the Sutcliffe laboratory at the Scripps Research Institute. They used directional tag PCR subtractive hybridization. So they were searching for messenger RNA species that they knew were in the hypothalamus, and they were wondering what they did. So in that initial paper, they said, we describe a hypothalamus-specific messenger RNA that encodes pre-pro hypocretin, the precursor of a pair of peptides that share substantial amino acid identities with the gut hormone secretin. Our name, hypocretin, is intended to indicate a hypothalamic member of the incretin family. And they concluded that the circuitry revealed by the immunohistochemistry suggests a role in nutritional homeostasis, eating behavior. So nothing about sleep at this point in 98. So the other group was the Yanagasawa laboratory at Texas Southwestern. They used a cell-based reporter system. They were searching for ligands for these 2 G protein coupled receptors, which at that time were sort of defined as orphan receptors because they didn't know what attached to them. And in their paper, they said, we have identified 2 novel neuropeptides, both derived from the same precursor by proteolytic processing, that bind and activate 2 closely related, previously orphan G protein coupled receptors. And they conclude their study suggests a physiologic role for the peptides as mediators in the central feedback mechanism that regulates feeding behavior. Nothing about sleep at that time. However, it only took a year for that to come about. So it was discovered or identified in several different species that the orexin hypocretin system had abnormalities in both animal models and in the human representation of narcolepsy. And once again, amazingly, 2 different groups, one working with the knockout mice and the other with the canine narcolepsy dogs, found abnormalities related to this system. So we know now that there are numerous ascending pathways and several different neurotransmitters associated with alertness and wakefulness. And we appreciate now the fact that the orexin systems helps to stabilize wakefulness through attachments to these various centers. And we also know that the orexin activity is low during sleep, and the ventrolateral preoptic nucleus helps to quiet down many of these wake-promoting neurotransmitters. Clifford Saper, Tom Scammell, and others have sort of used this model of a flip-flop switch with regard to the orexin hypocretin system in how it stabilizes wakefulness and sleep as well. So with regard to insomnia, we've seen already that there are these two orexin peptides, A and B, and there are widespread projections, and there are the OX1 and OX2 receptors for these. And so the whole system promotes arousal, stabilizes wakefulness, and there are abnormalities associated with narcolepsy. And so the question came up very quickly, if in narcolepsy, the orexin system activity is low, what about those insomnia patients who are hyper aroused? What if we bring down their orexin hypocretin tone? Will that help with their sleep? So a lot of pharmaceutical companies started working on this right away. I wrote a book on insomnia 20 years ago now. And in this book, I said, with this advancement in the understanding of the etiology of the sleepiness of narcolepsy, is there any potential insight for the opposite symptom, the sleeplessness of chronic insomnia? And I quote Emmanuel Mignot here, saying that he conjectured that perhaps the reverse situation, a hypocretin excess, could cause an underlying imbalance in the sleep-wake cycle that makes the experience of sufficient sleep unattainable for some insomnia patients. So as I mentioned, pharmaceutical companies worked right away, and it was only about 2007, just a few years later, that the proof of concept article was published, and this was with a compound, almorexant, which was never brought to market. But these researchers at the pharmaceutical company found that the blockade of both orexin 1 and orexin 2 receptors with a dual antagonist caused somnolence and subjective and objective signs of sleep without any evidence of cataplexy, because of course you wouldn't want to have that happen. So here's what we have right now. There is suvorexant, there is limborexant, there is daridorexant. These are all approved by the FDA, and also there are DORAs, dual orexin receptor antagonists. Here's an example of an investigational compound, seltorexant. This is specific for the type 2 orexin receptor. So here's what we have right now. These are the ones that I mentioned, DORA, and 2-SORA. I'll say a few words about each of these. So pharmacodynamically, dual orexin receptor antagonist, working through the hypothalamic neurons and blockade of the receptors. So suvorexant promotes sleep by decreasing orexin-associated CNS arousal. Pretty rapidly absorbed, elimination half-life about 12 hours. There is dose-dependent potential for residual sedation. The indication is for sleep onset, sleep maintenance. Only contraindication is narcolepsy, main adverse reaction, somnolence, Schedule 4 controlled substance. Here's limborexant, next one that came along. While there are some differences in the pharmacodynamics, they're very similar. Pharmacokinetically, really the major difference is the elimination half-life, longer, 17 to 19 hours. Same indication, same contraindication, same adverse reactions, Schedule 4 controlled substance. Here's the daridorexant, the most recent among these. Pharmacodynamically, very similar fundamentally. Pharmacokinetically, elimination half-life here is shorter at about 8 hours. And once again, the indication is the same: sleep onset, sleep maintenance. Contraindication is narcolepsy, adverse reaction, somnolence or fatigue, headache, controlled substance. Nothing new here. It just summarizes all the information that I have presented for these. So there's a lot of overlap. The warnings and precautions in the label for suvorexant are CNS depressant effects, daytime impairment, worsening of depression, suicidal ideation, complex sleep behaviors, sleep paralysis, hypnagogic hallucinations, cataplexy-like symptoms, compromised respiratory function, probably not a major issue for any of these. And these are mostly class labeling, including the need to evaluate for comorbid diagnoses. Limborexant daridorexant. They are exactly the same in the labels for all of these. Very quickly, we'll look at the adverse reactions, and I'll, just jump down to somnolence because, that's the issue of greatest concern. Placebo, 3%, in the 15 milligrams, 20 milligrams, subjects, 7%. So there is a relationship here. If we then look at lemborexant, somnolence, lethargy, fatigue, sluggishness, dose dependent. You can see going from the placebo to the lemborexant at 6.9, the lemborexant 10 milligrams, 9.6. So there certainly is that potential for daytime sedation. And here's the daridorexant. Again, focusing on the somnolence, fatigue, sedation, lethargy, hypersomnia. Placebo, 4%, the 25 milligrams, 6%, the 50 milligram, 5%. So somewhat less problematic. Last thing I want to talk about is the fact that these are Schedule 4 controlled substances, which might seem odd. And, the reason they fall into this category is because there are studies that are required for approval of sleep medications for abuse liability. What they do is they recruit community recreational sedative users, and they bring them in and they will give them a placebo, an active comparator, and whatever medication it is that's being evaluated. And in the daytime, they're given the doses and they're asked to rate them on various scales. And so for all three of these DORAs, there is a certain likability because it has an effect that is different from placebo. So therefore it falls into that category. So it's not that there's evidence of any physical dependence or withdrawal effects. And ironically, with these medications, we know that orexins have a central role in neural reward circuitry. And there's actually a lot of research now about using these medications therapeutically in people with substance use disorders. And you can find on, PubMed studies using these medications in the treatment of cocaine use disorder and with opioids, alcohol, nicotine, even cannabinoids as well. So there is irony there. You have to wonder what would happen if trazodone was brought up for approval by the FDA and the DEA for treating insomnia. There's a good chance it would fall into this scheduled category as well, because there were studies that looked at likability, but it was never an issue because it was never brought up for approval for those. So we just come back to my grid here of the wide variety of things. I think we're really in a golden age of insomnia pharmacotherapy because we have so many options, particularly with the regulatory approved medications, since there are a lot of different pharmacodynamic medications to choose from, a lot of pharmacokinetic choices as well. And that takes me to the end, and I'm happy to try to answer questions that you might have.
Thank you so much, Dr. Neubauer, for this excellent informative talk. And if there's a question from anyone, please feel free to put it in the chat room, or you can unmute yourself and ask the question. I have a question, Dr. Neubauer. So, as a sleep physician, when we have patients with insomnia, the stepwise approach, usually we start with CBTI and then we sort of go into medications. But still, that's how I feel that, when we start medications, the orexin receptor antagonist is not the one that I usually go to. What would be your, your go-to? What kind of patients would you prescribe orexin receptor antagonists, or what are the points that you would start this medication on?
Yeah, well, so I think that's an important question. And I think there are a lot of cultural factors that lead us in one direction or another. I think the big question is, why are so many why are so many people prescribing trazodone? What choices are being made, and on what evidence is that based? And I think that over time, probably the orexin antagonists will be used more when we're more familiar with them, when there are fewer hurdles. with prior authorization or insurance requirements and stepped care required from the benefits managers. The appeal for these medications, is that it's very targeted. And so you avoid a lot of the potential problems that people may experience, with the benzodiazepine receptor agonists, and, what I use is so personalized for patients. There are factors of age, sex may be a factor as well with some of the benzodiazepine receptor antagonists, and women perhaps metabolizing things like zolpidem more slowly. Comorbid conditions, co-administered medication. So, the patient's history. So I'll take all of these into consideration. So it's hard to say, what drug do you use? Because, that's why I say we're in a golden age. So we have so many that are available to us right now. But back to the issue of the DORAs, I think in the future, probably they'll be used more. And I think when we recognize, the benefits of that targeted activity. I can add to that, though, going back, the several decades when we first started thinking about whether some pharmacologic approach to blocking orexin activity might be possible, the thought was for those hyper-aroused insomnia patients. So perhaps those people who, give us that history of not being able to get to sleep, stay asleep at nighttime, but maybe more importantly, they're the people also who talk about in the daytime how they used to be able to take a nap and it was really nice and refreshing for them, and now they struggle, they crave sleep, they're wired and tired, but they can't sleep at all. And I think that maybe that's a population that might be especially finding the orexin antagonist somewhat more beneficial. They're all relatively new, and I think we need a lot more experience with them to figure out who the best patients are.
Great. Thank you so much. And I have a few questions here in the chat room. The first one's from Daniel McNally. Given that some studies, I think Scott White from 10 years ago, have shown an increased mortality in uses of anxiolytic and hypnotic, what do you think the mechanism is for that?
Well, population-based studies, I think we need to understand those a lot better. And there's very mixed literature on, first of all, with benzodiazepines in general, and then trying to carve out, what effects there might be associated with the non-benzodiazepines as well. There are studies that show, for as one example, increased falls with these medications, and ataxia can be measured with a lot of benzodiazepine receptor antagonists, at least within a few hours after taking the medication. On the other hand, what they don't necessarily measure is fall risks associated with people who are untreated for insomnia and who are up during the nighttime. And so there are some studies that support increased risk for non-treatment as well. But no, I don't have some single pathological process that would account for a greater mortality. There's literature about dementia as well, and I believe a recent large-scale study has suggested that there probably is not significantly greater risk with dementia associated with the medications. But clearly, I think we should be using all of them cautiously.
Thank you. And we have next question from Toshiba Kumar, which is a very practical question. Unfortunately, in the real world, insurance requires failure of zolpidem before we can consider these newer agents. I sometimes know that the zolpidem is wrong medication. What would you suggest?
Oh, well, I think we have a lot of choices. And so, I prescribe zolpidem for some patients. I think it's very reliable in helping people get to sleep. But, I'm also cautious in, thinking about what risks there are with any particular patient and why I might or might not want to use that medication with them. We've talked about the low-dose doxepin. I think that's a really good choice to try for people. With sleep onset, Ramelteon, or even, some trusted product of a dietary supplement of melatonin, sometimes is the answer for some people. And I agree that there are hurdles, with the dual orexin receptor antagonists, but I've had less trouble recently prescribing them than when they first became available.
And then I have next question from Richard Zhang. Given the variety of melatonin manufacturers out on the market, are there specific brands that you would recommend over another?
Oh, I'm sorry.
Melatonin, the melatonin, the different.
Melatonin. Well, yeah, I don't know of a particular product, but I know that there are, good manufacturing certifications that are on some products, or USP approved. So I would look for something like that to try to get a better sense of what might be, more reliable medication, or at least that it represents what the label says.
Yeah, at least the USP level, right?
Yes.
Yeah. Okay, the next one is from Parvati Singh. Is there a medication you are more likely to use to treat insomnia in patients with chronic pain who are on opioids?
Oh, well, so of course, that's a really good question because of the potential problems with benzodiazepines. Probably less so with non-benzodiazepines. And, once again, it comes down to the patient and what risk factors there are, what other sort of compromise there might be, with their respiratory system in particular. I may have some people who would be on a lower opioid dose, and perhaps a low dose of zolpidem, or one of the other non-benzodiazepines. But I certainly would try to use something else first to see if that would be beneficial for them. So it is something that we should absolutely be cautious about with all patients, combining any benzodiazepines and opioids.
Thank you. The next question is from Stuart Mann. Has melatonin receptor agonists together with food present the same glucose elevation risk? Why should melatonin receptor agonists work any better than just melatonin?
Oh, yeah, sure. So if the question is melatonin versus an FDA-approved medication like Ramelteon, why use one or the other? Yeah,
I think so.
So I think the number one reason is a pharmaceutical product. You know absolutely what that is. And with these dietary supplements, they're simply not regulated. And so you really don't necessarily know what you're getting. But, I think that most of the dietary supplement types of melatonin probably have melatonin. And fortunately, dose really doesn't matter very much. You don't want it to be 2 and 3 and 4 and 5 times more or less than what the label says. And there have been recent reports that I think have been sort of alarmist about melatonin labels not being accurate. But in a lot of cases, the label would say 5 milligrams, and the research laboratory would find that it was 6 milligrams or 3 milligrams. And for the melatonin specifically, since there's no dose response curve, it just doesn't matter. I wouldn't want it to be 20 milligrams when it says 5 milligrams, but I think a little bit of variation probably doesn't matter that much.
And the last question that I have here is from John Cronin. Do you have an opinion on sleep aids that might be used preferentially in patients with COMISA?
I don't mind prescribing someone, zolpidem or one of the others. I only mentioned zolpidem kind of representing that category because, for a lot of people, Zaloplan is too short. S-zopiclone is perfectly reasonable for people depending on their own metabolism, as long as you can avoid next morning effects. If somebody's using their CPAP machine, I really don't worry about using zolpidem. I have prescribed that and the others for patients over a period of many years, if it's going to allow them to fall asleep with the CPAP mask in place. I think there is not great worry about respiratory depression with those medications, especially at the prescribed doses.
Yeah, and there was also a study that showed that the initial period of the CPAP, you could, I think 2 to 3 weeks with the SOP clone. If you use that, it improves the compliance with CPAP. That's something that you do, and would that be something that you could continue if that improves compliance?
Yeah, I don't end up doing that very often because, so many people do well with CPAP and find that they're able to fall asleep with it okay. But on follow-up, if somebody's really having a struggle falling asleep with it and other strategies don't work, like trying to, have them use the mask at other times when they were awake to try to get used to it more. But yeah, I'm certainly open-minded about using any of those medications.
Perfect, thank you. And then there's a comment from Daniel McNally. The Office of New York Attorney General investigated in 2015 a variety of herbal supplements from 4 major retailers, GNC, Target, Walmart, and Walgreens. The test determined that only 21% of the products actually had DNA from the plants advertised on the labels and not aimed at sleep products.
Right. I think that whole category of the dietary supplements is very problematic, not just for melatonin, but for other things as well. But at least more recent studies that I've seen of melatonin in particular, there's been, a reasonable amount of it, even if not exactly what the label says.
Yeah. Yeah. And just a quick question, not related to this talk, but as we discussed offline, the importance of CBTI and insomnia, and given the shortage with the psychologists, I think that's everywhere. What do you think are some of the ways that we could overcome that?
Well, there are the digital types of CBTI. It's sort of a mixture of products that are out there. Some that costing a moderate amount of money. There are many that are meant to supplement actual CBTI, like the CBTI coach. I think it's going to be a bigger business, and so I think that's part of the future. And until we can get more certified people out there who are using CBTI in person, and telemedicine, of course, is helping somewhat.
Right. Well, great. It's exactly 3 o'clock. Thank you so much, Dr. Neubauer, for this excellent and very informative talk. And thank you, everyone, for joining us. See you next week.
Thanks. Bye.
Thank you. Bye-bye.